warahmatullah. Good morning, good afternoon, good evening, everyone, and welcome to this webinar. It's 57 actually webinar out of our WEBi series, which is one of successful knowledge exchange and knowledge sharing and expert dialogue initiative that EMPHNET used to organize it on a monthly basis in partnership with our respected experts and partners, trying to tackle the key, important, and priority public health issues that burning in our region. And today's webinar is titled Mental Health in Humanitarian Response, Challenge, Workforce Gap, and Opportunities for Action. And this webinar actually coming timely as we are observing the annual Humanitarian Day on 19th of August. But also it's recognizing an important topic and public health area that in our region, in our continent, is growing public health issue, given the ongoing humanitarian context in the region and the effect of many countries with conflict and even natural disasters and other kind of pandemic, epidemics, which both affect the healthcare and health professional, but also the entire community, general impact on public health and public health system, but also one of the critical areas that critically affected and impacted is the mental health and well-being in our communities. So at any start of this, I would like to welcome actually our respected speaker who will be joining us throughout the webinar, Professor Ragnhild, who is coming with a wealth of experience in the mental health area. I will introduce her properly before her presentation. Dr. Zaina from the Ministry of Health Somalia, who is leading the mental health department in the ministry, and also she's representing a good example of a country in the region who have been witnessing a long-standing humanitarian context where definitely the consequence of on mental health in general and system will be very good representation on how this is impacted. And we have our Dr. Amna, our technical specialist from EMPHNET, who is currently actually supporting one of the critical initiatives that we are doing in partnership with Africa CDC in order to bridge the gap in health professionals and to address mental health issue. As an start, one of the countries that heavily impacted recently with the humanitarian crisis is Sudan. So we have a short video prepared by the communication team just showing the general impact on the system, and then we will start our presentation. So Ammar, if you can kindly share the video.
Cultures and communities. Sudan is a land of remarkable diversity, shaped by its rich history, vibrant cultures and communities. From the banks of the Nile to its diverse regions, Sudan is home to people with different languages, traditions and ways of life, united by a deep sense of community, resilience and belonging. For generations, this diversity has shaped Sudan's identity and communities, with health and well-being at the heart of strong and resilient communities. But in recent years, Sudan has faced a devastating reality. The war that erupted in 2023 has disrupted lives, displaced communities, and placed immense pressure on essential services. The health system has been among the hardest hit, with many health facilities damaged or destroyed, severely affecting their ability to provide essential healthcare to communities in need. The damage to health facilities has disrupted critical services for women and children, limiting access to routine childhood immunization, maternal and newborn care, and essential reproductive health services. For many families, the loss or disruption of these services has made accessing timely and life-saving care increasingly difficult.
والحرب بالتأكيد أثرت على القطاع الصحي تأثير بالغ. أول تأثير كانت نزوح الناس وغياب عن المتابعة الدورية لأمراضهم. الأمر الآخر هو نزوح الكوادر الطبية أيضا، وهذا يعني بتأثير مباشر على تقديم الخدمة. الأمر الثالث هو التخريب المتعمد على الأجهزة والمعدات الطبية.
Health workers on the ground have witnessed firsthand the impact of the war on health facilities and the communities they serve. Their experiences tell the story of how the conflict has affected healthcare in Sudan.
رجعنا من النزوح، حاولنا نبدأ شغل في المركز القديم. كان في رعاية الأولية بس للأطفال زي الجرعات التطعيم، لأنه كانت أصلا ما متوفرة. بدينا في المركز القديم، فكان الشغل فيه صعب حقيقة. البنية التحتية مدمرة، الأجهزة أي شيء فيه منتهي.
تأثيرات الحرب على الخدمات بتاعة التحصين في الفترة اللي فاتت كانت حاجات كبيرة جدا جدا. ولا لما نجي على مستوى البنية التحتية قد تكون حوالي 60% من المراكز الموجودة عندنا دي كلها حصل لها تحطم. جزء كبير منها حصل له تحطم كلي. يمكن الخدمة بقت صعبة جدا جدا، حتى الطريقة للوصول للإمداد بقى حاجة صعبة.
Among the most concerning consequences has been the impact on children, with disruptions to health services resulting in missed opportunities for routine vaccination and leaving many vulnerable to vaccine-preventable diseases.
تأثير الحرب للأطفال أثر، يعني جاب الأمراض بتاعت الطفولة اللي هي سنين ما دخلت البلد.
كان في فترة الحرب كان في مشكلة في المراكز الصحية، لأنه كان عندي بنتي كل معدات التطعيم بيكون التطعيم غير متوفر دائما، ولما يتوفر التطعيم بيكون في زحمة كبيرة شديد، لأنه في كمية من الناس بتجي من مربعات مختلفة عشان هي تقدر تاخد التطعيم.
Despite these challenges, Sudan's Federal Ministry of Health, together with other partners, has continued working to mitigate the impact of the conflict and prevent disease outbreaks. These efforts include achieving a major milestone, with Sudan becoming the first country in the region to introduce the malaria vaccine into its routine immunization program, despite the widespread disruption to health services caused by the conflict.
كان أكبر هم هو إدخال لقاحات نتيجة لهذه الحرب. تفشت كثير من الأمراض، تكاثر نمو بعض نواقل الأمراض، وهذا اضطرنا إلى تدخل في مكافحة هذه النواقل. وهذا التدخل اضطرنا نشتغل بآليات سريعة جدا في أن تكون هناك استجابة للطوارئ. وهناك هذه الاستجابة تمثلت في أن تكون لدينا سرعة في إدخال في تطعيم الأطفال، تطعيم الأمهات، وأدخلنا لقاح الملاريا كأول مرة في السودان أثناء فترات الحرب. وكان هذه التطعيمات كانت مهمة جدا في حماية أطفالنا والأمهات من الملاريا، من الكوليرا، ومن بقية الأمراض.
In response, EMPHNET has continued its commitment to Sudan, working alongside the Federal Ministry of Health to assess immunization coverage and health facility readiness across 4 states: Khartoum, Jazeera, Sennar, and West Darfur. The assessment is generating critical evidence to better understand how the conflict has affected immunization services and where the greatest gaps remain. These findings are helping guide efforts to rehabilitate vaccination centers, strengthen cold chain systems, reach zero-dose and under-immunized children, and improve community engagement and disease surveillance. The work will now expand to 4 additional states, generating more evidence to support Sudan's recovery and strengthen immunization services, so that more children and women can access the essential vaccines they need.
بحمد الله يعني وتوفيقي وعزم الرجال وجهد الناس اللي كانوا شغالين من أول أيام من إنقاذ التطعيمات الموجودة في السلسلة المركزية لترحيلها إلى الولايات لإنشاء مراكز ولاهية لتخزين الأدوية بتاعت التطعيمات الأطفال. الحمد لله قدرنا من هذه المراكز الولائية أن نستعيد خدمة التحصين بصورة كبيرة لحد ما وصلنا ل 83% تغطية بالتطعيم الروتيني في كل السودان. والحمد لله الآن بمعاودة الشركاء نحن مواصلين في إدخال تطعيمات جديدة إن شاء الله داخل السودان كلقاح الملاريا وكلقاح الكبد الوبائي EBA. الحاجات دي دائما بتتطلب انه يكون في بحوث مستمره. نحن نشكر الشبكه الشرق الاوسطيه على انها هي كانت داعمه لنا في مجال البحوث بالذات ومتابعه هذه اللقاحات ومتابعه الاثر وتقبل المجتمعات لهذه اللقاحات الجديده. ونحن دائما بنطلع لشراكات زي دي، شراكات علميه بتنتج دلائل وبتنتج ادله مبنيه على البراهين.
The road to recovery will take time, but Sudan's resilience and the continued efforts of its health sector and partners offer hope for a stronger future. As this journey continues, generating evidence and documenting the realities on the ground will be essential to guide needed actions and support efforts to build a stronger and more resilient health system for the people of Sudan.
Thank you for this for showing this video. And actually, it may appear not connected with the topic of the webinar, but what the message that we are trying to convey through this video, even the programs where there is a lot of attention, for instance, like immunization, even for these programs in our region where there is a lot of allocation of funds and there is global attention and support, there is a lot of backsliding and heavily impact in conflict and humanitarian. Either the humanitarian, when the pandemic properly document the impact on this in the health system, or armed conflict, which Sudan is a good example of that. So now we need to ask ourselves the question, if the situation for this well-funded program like that, so how come the impact will be on mental health, which is even in the normal development context, it's overlooked, not properly addressed, and it's not even in some ministries or in some areas there is no dedicated team handling this. It's not well addressed in the strategies and in public health priorities. And mental health for EMPHNET is one of the critical area, and we are very happy to have this strong partnership growing with the Ministries of Health and also with other partners like Africa CDC coming up with new initiatives to enhance the knowledge. So what we are trying to do today is to examine and to see the global burden of mental health and its implication on health system normally and during the humanitarian things. And then we zoom in, looking for the health workforce, for the evidence, for the surveillance, for the epidemiology and data, where these facts shape actually the health agenda and priorities at the national level and at the regional level. And then at the end, we are going to introduce one of the new initiatives that we are currently working on, which we are very proud actually on the success on introducing this initiative in our countries and with our partners. So as a start, we will be starting on the first presentation, which will be discussing the growing mental health burden and the implication for health system and humanitarian response. And Professor Ragnhild will be handling this topic. She is a senior advisor of global health at Norwegian Institute of Public Health, an associated professor of global mental health at the Center of Crisis Psychology, University of Bergen. She is currently seconded to the Africa CDC, and I consider myself lucky to have the opportunity to interact with her in person in multiple initiatives for the African continent, strengthening the mental health and mental health leadership in the continent. She contributed extensively to the research related to mental health, psychological support during and after emergency and in early childhood development, which is again a critical area. And she has been a humanitarian diplomat and clinician, and having a leadership position in international development cooperation. So the floor is yours, Dr.
Thank you so much, Dr. Nada, and good morning, good day, good evening to everybody. It's an honor to be with you and speak on behalf of the Africa CDC. As you said, I am seconded to Africa CDC, so I'm based in Addis Ababa, where I have been for 2 years now, and it's good to see many new and old names amongst the participants. And before I start, I'd also like to say thank you for the film from Sudan. Sudan has a very special place in my heart. So it's heartbreaking to see the damage, but it's also so encouraging to see the resilience and the will to change and to rebuild a resilient health system and society. Although the film focused on vaccines and not on mental health, I still think it's very relevant because it focuses on primary health care and essential health services and health system disruptions. And as I will soon speak more about, these essential services really are also important to consider when we talk about mental health. One of my key messages will be exactly that, integrating mental health into primary health care. I'll share my screen with you, and I hope you will see everything well. The topic I've been asked to talk about is one I welcome very much. First, I'll talk about the growing mental health burden globally and also in the region, and then I will talk about implications for health systems and for humanitarian response. So first, I'll talk about the burden of mental health problems, and then I'll talk about what we can do, both in terms of strengthening and building health systems and when it comes to humanitarian action. Some of the important sources that I lean on are here, and feel free to reach out to me if you want more of the references that I use. I am using the Mental Health Atlas from WHO and the World Mental Health Report from WHO, but also several of Africa CDC's sources, including our strategy for non-communicable diseases, injuries, prevention and control, and mental health promotion strategy. An overall picture for the crisis, you can see here in numbers, how 970 million people are estimated to live with mental health disorder, meaning 1 in 8 in the global population will be affected, and how billions of productivity days are lost. Mental health disorders are a leading cause of disability globally. And as you mentioned, Dr. Nada, it remains one of the most underfunded areas of health in all countries. Why is this so important? Well, one reason is that mental health conditions affect so many people. We all know somebody affected by mental health conditions. Nearly half the population will be affected in their lifetime. If we look at depression and anxiety alone, which are the most common mental health conditions, one estimates that 600 million people suffer from these conditions. And mental health disorders are main reasons for years lived with disability. In fact, 1 out of 6 years with disability. Talking about years lived with disability is quite important when we talk about mental health, because we don't only talk about how many people die from a disease, but when it comes to mental health conditions, many people can live for many years with mental health conditions, and that has also to be taken into account. That means reduced productivity, reduced well-being, reduced health and social contributions. People with serious mental health conditions die earlier than other people. And this is even if we correct or adjust for suicide, for example. People with serious mental health conditions die between 10 and 30 years earlier, depending on which region we're in, mainly because they do not get adequate medical care for physical conditions. This is also a human rights issue. So people with mental health conditions or serious mental health disorders do not get adequate care for cancer or for heart disease compared to the rest of the population. And this is a global phenomenon. I mentioned depression is very common already. Postnatal depression affects about 15% of new mothers. This is very serious because it affects not only the mother, but the whole family and the baby. And mental health conditions amongst the most common when it comes to affecting children and youth. And we estimate that up to 20% of children are affected by mental health conditions. Suicide and suicidal behavior should be mentioned, especially because it is happens far too often. And it's estimated that 727,000 people die annually by suicide. Most people in low and middle income countries. It's actually the third leading cause of death for young people. And globally, many more men than women die from suicide. However, there are exceptions to these numbers. There are some countries where suicide amongst women is common, more common. The regional average when it comes to suicide, when it comes to the EMRO and MENA regions, seem quite low compared to the global. However, these data are likely to be poor, which is an issue already about poor data, that it's underreported. And there are major differences between the countries in the region. For example, Somalia and Syria have higher numbers than some of the others. And there are also major difference between groups. So some groups, such as refugees and migrant workers, have higher numbers. To continue the regional perspective, the mental health disease burden in the MENA region has increased drastically since 2020, most likely driven by COVID-19. Because COVID-19 affected many people, but also it's possible that it made us better at reporting, but also by conflicts and economic instability. So conflicts and economic instability are high risk factors for mental health conditions. Major depressive and anxiety disorders are leading drivers of disability-adjusted years, especially impacting women and adolescents. The Eastern Mediterranean region faces a significant mental health burden, which is actually the second highest of the WHO regions. An important concept when it comes to global mental health is the concept of treatment gap. Treatment gap means that difference between people who need mental health care and who actually receive it. Because most people with mental health conditions do not receive treatment. They do not receive quality treatment. They do not receive acceptable treatment. This treatment gap is particularly high in low-income countries. In some of the poorest countries, the treatment gap is actually over 90%, meaning that only 10% of people receive good care for mental health condition. In addition to that, we have a big challenge in that very little of a health budget goes to mental health, maybe about 10%. And of that 10%, a very small proportion will go to primary health care or community-based care. In fact, generally about 90% of the health budget part, that small part that goes to mental health, about that 90% is likely to go to specialized care, especially mental health hospital in main cities, meaning that this is care that is not accessible for most of the population and often not the type of treatment that people would like to have for themselves or for their loved ones. We have a big challenge of inequity or an unequal distribution, both of the burden and of resources when it comes to mental health. So although the majority of the global burden of mental health disorders is located in low and middle income countries, most of the resources are in high income countries. Africa has a global population share of about 14% and 25% share of the global burden of disease, but only 1.3% share of healthcare staff. This is a very low share. Africa has only 1.4 mental health workers per 100,000 people, which is much lower than the global average. So looking at the mental health atlas, which gives us an overview, you can also see this gap. Here's an illustration of the disparity between the health budget and the actual human resource capacity within the region. And it highlights why community care is lagging due to shortage of personnel or mental health personnel. Here you can see the target, the recommended number, for example, when it comes to health budget is about 5%, but in the EMRA region, it's 1.8. And again, when they're similar when it comes to, for example, psychiatrists or mental health nurses or psychologists. I already mentioned briefly that conflict is one of the risk factors for mental health conditions. Also, that also goes for all types of emergencies and humanitarian settings. The emergency conditions, the humanitarian conditions, have a negative impact on mental health and psychosocial well-being and increase the risk of mental health conditions. However, most people, even when they experience serious distress, will not develop serious, long-lasting mental health conditions. This is an important thing to remember. It doesn't mean that everyone in a humanitarian condition in an emergency or a crisis situation will need therapy or treatment. In fact, the minority is likely to need treatment, but there's still an increased risk, and it's estimated that 1 in 5 will develop a mental health condition following severe emergencies and conflict. But 1 in 5 means 4 out of 5 do not. And we also have to remember that although emergencies are likely to make things worse, there are also people there who had pre-existing problems, and they are particularly vulnerable during an emergency. And it's also possible that the aid effort can make things worse, and this is something we really strive towards avoiding. What are the key challenges? Or why do we have this situation? Well, one of the problems is that many countries do not have updated and good policies and legislation. Many countries still have very old colonial policies or legislations from 100 years ago that do not secure people's rights, do not treat people, and where people's dignity is not protected. Another challenge is the lack of services and facilities. As I mentioned, the treatment gap is so big. And often people do not ask for, there's little demand as well, because people are afraid, or there's so much stigma attached to getting psychiatric or psychological care that people try to avoid getting this type of support. There's a lack of human resources for mental health personnel. Human rights violations are far too frequent. We have poor data, poor surveillance for mental health. I'm glad we are going to talk more about this later. We lack financial investment, both domestic and globally, and sustainable financing. There's a lack of access to health consumables and technologies, as you mentioned already, from Sudan for vaccines, but there's also go for psychotropic medicines. And the multi-sectorial coordination is too often poor and insufficient, both when it comes to prevention and control. Multi-sectorial action really is very important. So many of the problems we have when it comes to mental health, both those that cause mental health problems and when it comes to finding solutions, demand that we work together across sectors, across ministries, across different professions. The health sector will not be able to solve all of these problems, that we do know. We know violence is a big risk factor. Health sector will not be able to solve that. Poverty is a great risk factor. Again, doctors and psychologists are not that good at fighting poverty. When it comes to what can be done, we have seen a shift, a paradigm shift, a different way of looking at mental health in recent years, which I think gives us great hope. We see now that mental health spans from presence of good health to poor health and disability. And that gives us also room for a lot of different types of intervention, which includes promotion of good health, not just treatment, prevention, not just treatment. We now recognize the importance of lived experience. Without taking lived experience seriously, without listening to those who know what it's like, we are not going to achieve our goals. We now understand that economic and social problems are great and important determinants and have to be taken seriously. If you are worried about paying your bills, if you're hungry, if you don't have proper housing, talking therapy is not going to be sufficient at all. And we now understand that psychiatric hospitals and psychiatrists and psychologists are not the only solution, far from it. Self-help, communities, community-based interventions, that is one of the greatest hopes we have. The implications from all of this is that we need a public mental health approach, not just a clinical. We need to look at surveillance, we need to look at prevention, we need to see all of society. We need better financing. We need to integrate mental health into primary health care. A community health worker will be able to detect mental health conditions and support people with mental health conditions in most instances. We need to take lived experience seriously and use a human rights approach where we take people's dignity, cultural appropriateness seriously. Community-based care, treat people, provide services as close to where you live as possible. And as I mentioned, multi-sectorial action and coordination. Also, we have many ways of working outside the health sector, including in schools, in early childhood, and we know a lot about what can be done for suicide prevention, including better legislation. Another implication is to build public health leadership and primary care capacity, to strengthen workforce capacity, and to strengthen surveillance and data for decision-making and accountability. These are very much at the core of public health approach, and the illustration I use here is from the Africa CDC Mental Health Leadership Program, which has 4 pillars, from the Kofi Annan Leadership Program, the FETP, which we'll talk about, the Field Epidemiology Training Program, to short courses to promote public mental health and strengthening civil society and organizations for people with lived experience. What about when it comes to MHPSS? By that I mean mental health and psychosocial support in emergencies. Here are a few key points. Integrate mental health and psychosocial support into our general emergency preparedness and response as part of many sectors, including in peace building. Link the normal health system. We talked about building resilient health system in the film. Link those health systems and other care and protective system to mental health and psychosocial support in emergency. By that I mean emergency response should build on and support our normal systems, our sustainable systems, and they should never harm them. Our normal sustainable systems should prepare for emergencies so that we don't build parallel systems. We need to make sure that what we do is appropriate in that context. That is localization, the part of a community where people who are concerned, people who are affected are at the core, with community involvement and participation. We see this in the Ebola response in DRC at the moment, that involving communities, working from communities is central. Otherwise, there will be hostilities, there will be misunderstandings and rumors. And incident management plans and structures should include mental health and psychosocial support. I have some references, and I'm happy to share those if anybody wants them.
Thank you, Professor.
Thank you so much for listening to me.
Thank you, Professor. Very interesting. You took us through a very comprehensive presentation showing the gross burden of mental health, but also handling the critical functions that is currently absent in the system in handling mental health in regular routine things, but also considering mental health as an integral part of early preparedness and response. And also one of the key things that clearly highlighted during your presentation is the fair data available, particularly in our region where our systems are not designed to show the burden and to help actually in prioritizing mental health. You raise issues related to allocation of resources, equity, but also you suggested some solution prioritizing the work at primary health care, which is the most closest service delivery point that for both prevention and health promotion, but also for initial care that closely linked with the community, including the community level of intervention and powers of the communities in engaging in mental health care. And also you highlighted the issues related to the human rights, the voices of people with lived experiences, and all these things. So please, if you have any comment in the chat, if you have any questions, Please make sure that you write your questions in the Q&A box. So we'll discuss it towards the end of the webinar. And now we will be moving to our colleague and respected expert, Dr. Zainab Ahmed, who is the National Manager for the Mental Health and Substance Use in Somalia, Federal Ministry of Health. She had an experience of over a decade in mental health, public health, and emergency response. And she needs the nationwide effort in advancing MHPSS governance policy and service integration. She also worked closely with the government institution, UN agency, and international partner in expanding right-based care for crisis-affected population. And she's pioneering in research linking youth mental health and peace building. She's active driver emergency response, helpline system, and capacity building for frontliner across Somalia. Mental health is always acknowledged as public health priority in our meeting with Ministry of Health Somalia, and they are trying to put more effort and emphasis as this critical priority. So Dr. Zainab is going to talk about mental health, workforce, and information system gap in humanitarian response, building on the Somalia as a model, showing the case as one of the humanitarian affected countries in our region. So the floor is yours, Dr. Zainab.
Thank you, Dr. Adna. Assalamu alaikum, everyone. Good morning and good afternoon for everyone. And thanks, EMPHNET, for inviting me to share Somali perspective on mental health and humanitarian response. Today, I will focus on challenges we are facing and what are available for workforce and service. To tell you where we are opportunities and action for workforce. My main advocacy message for this session is mental health is not optional humanitarian. To add on it, it's a core health system and resilient function. For Somalia, our priority now is to move from fragile activity and to work to coordinate sustainable resilient mental health system. Next, please. In Somalia, in humanitarian crisis that affect much more mental health, the conflict and displacement and disaster are prolonged crisis and distribute the livelihood, essential service and health system itself. This pressure also create a pressure on governance, finance, service delivery, workforce coordination, and continuity of care. So the question is not whether the mental health is needed. The question is where our system can deliver the mental health service reliable when we need it to increase the service are distributed. This is why we need MHPSS capacity across preparedness, in emergency preparedness, response, and recovery and resilience. Next. The gap, what Somalia is forced register to tell us. Can you go back? Yes, thank you. This workforce register provide us with important of planning. Also, I wanted to emphasize that it's not yet a national workforce census. We have 132 names submitted for last workforce analysis we did. 48 of that show us that submitted by recorded workforce associated with a national and international NGO is nearly 89%. Are 20 of them are most of them are between age of the 20 and 40 years old. This is the largest professional cadre, followed by different cluster by health, education, and protection. This shows us that MHPSS is required as cross-sector workforce approach, but also highlight the need to validate the strengths of these data. Next. The key message for workforce we essentially is that the gap is not simple, but it's number of the workers. We need to look at the 5 things together: available, comprehensive, supervision, deployment of data. We need also to know who is available, where they are allocated, what they are qualified and to provide, who is supervising them, and whether they can actually reach in crisis-affected population. So our strategy question is, how do we move from a list of people to function and deployment supervision for workforce system? Geographically, this register also shows a significant concentrate in Mogadishu area. Since Mogadishu is the capital city of Somalia, we have recorded 64 records from Mogadishu, compressed with a much smaller number from Baydhabo, Kismaayo, and Kalkayo and other locations in Somalia. We should be careful not to assume that this mean of the workforce is actually concentrated, because the registration is biased, may also explain part of the difference, but is clearly telling us that we need to better regional comprehensive data for workforce. Next. Our goal should not simply to be working in the capital. We need also equipment, staff supported by regional hub supervision referral pathway. So the training is essential. Does not create a competence workforce. This assessment is needed for 5 important areas. When we're talking about training workforce, to concentrate on psychological first aid, basic psychosocial skill, MHPSS, trauma-informed care, since we have a lot of emergencies and prolonged conflict. So trauma-informed care is much important to equip the health workforce. Also self-care and well-being, because a lot of burden have been within the frontline health workers. This should also adapt according to the worker roles and level of responsibility, to follow by supervision practice, comprehensive competency assessment, and refresh support for membership also. So our advocacy is to ask is where needed to be fund competence, supervision and deployment, not only training they alone. So it's important always to follow up all these health worker trainees. Next. Supervision is not a critical cap for this registration. Showed that 112 records had submission entry, while 20 did not, but have supervision entry does not necessarily mean that the functions or supervision is taking places. We need to know how frequent supervision occur, who provide it, where the supervision is opportunity is qualified, and whether there is a clear pathway for acceleration. We also have to look for the need of national and regional supervisional pools to include remote specialized consultation for understanding for underserved areas. So most of our service is focused on the big cities, but not at the rural areas. Supervision must also related our fund of service function, not only information counters. Next, please. When we build in a workforce, it's not a health system, not around it. It's a long-term solution into the integration MHPSS into the health system, rather than creating a parallel system around humanitarian projects. This means to integrate mental health into emergency preparedness response and primary health care and referral pathway system. It also established a competence standard for supervision, rapidly deployment mechanism for better information system and meaningful involvement of the community and people with the living experience. And it's important, we need to protect the well-being of health and humanitarian workers themselves. Mental health need to be part of the preparedness and response and recovery as well. Next. When we look into the 5 advocacy action for Somalia, it's based on these findings. We have 5 practical advocacy priority. First, establish availability of national MHPSS workforce information system. Secondly is the financial cost of workforce planning that to include recruitment and retention and supervision deployment and staff well-being. Third is also to integrate into the primary health care and emergency preparedness and response. Fourth is the regional and regionalized workforce deployment beyond Mogadishu city so that everyone can have to reach the service and training. And fifth is to establish indicators that allow us to measure workforce capacity, service availability, supervision, and outcome. These actions require the government, partner, donor, and technical institution to work together to achieve it. Next. For advocacy message at this point, I wanted to summarize my first part of presentation with one message. We cannot build a resilient in humanitarian health system without the resilience of mental health workforce. Somalia already have a foundation workforce service and partner working across different sectors. These opportunities now is turning foundation into the national equipment and competence and accountability system. That means validation of workforce invested in competence, funding, and supervision integration, MHPSS, into the primary healthcare and emergency response, and using data to guidance deployment and accountability for future work. Next. The DHS show us the rising of mental health service signal. And now I wanted to bring another important source of evidence that the routine health information system, DHS data, showed a clear increase in reporting of mental health disorder contacting during this year, reaching out to 2,407 new reporting in July, and highly monthly valuable in this supply series. I wanted to emphasize that this service reporting signal not only population prevention estimation, but the message for planning is important as the reporting workload increase. Workforce capacity, supervision, and service readiness also need to be increased. Next. In 2026 is turning a point in reporting workload when we are comparing January to July 2026 with the same period in 2025. Reporting new case increased by 55% from 1,349 to 2,407 at the monthly endpoint show here. We recorded that 11,518 new reporting during the January to July. We more than 6,200 reported during May to July alone. Again, this does not tell us the population prevalence, okay? But it does raise an urgent operational question. Do we have enough workforce and service capacity to respond to increase the workload being reported? Next. The workload sign is strength at the case for investment. When we're talking about this, is important point in that we should not simply count cases. We should use the DHS information to make a decision about workforce deployment, service planning, supervision, referral capacity, and quality of improvement. We also need to interpret the increase on carefully consideration reporting, completeness, service recovery, and availability. And because of 2026 data only cover January to July, we should not compare the partial year figure directly with full year totals. But overall, the signal strengthens in the case of investment and better workforce planning. Next. Mental health service availability across health facilities. This slide gives us another perspective that distribution of health facility provide mental health service across different administration. The data cover 160 health facilities, and they show that the service availability is not evenly distributed across the country. This is important because workforce planning cannot be separated from service availabilities. We need to understand not only how many workers we have, but also where the service already existed, what they can provide, and whether the people can access a referral and specialized support. This is why workforce data, facility data, and geographical data need to be linked together. Next. Reporting the workforce in young and close to gender partial. There are also positive findings of the workforce profile among the 124 recorded with complete gender information, and workforce is already evenly divided between women and men. 49.2% female and 50.8% male. More important, 88.6% of the recorded workforce is between 20 to 40 years old. This is both in opportunity and responsibility. We have a relative young workforce, so we need to invest now to structure a career pathway, membership, and competence development and retention for this workforce. Next.
Zainab, if you can go a little faster because the time that we have.
I'll try much as I can. This also reinforces a geographical issue we discussed earlier, other than the recorded area. It can show you the different area, the proportion of the workforce. Can we go next? The health lead register also tell us something important about who is currently carrying much of the recording of MHPSS capacity. Health is a large, important professional catalog, but the national and international NGO account for most of the organization recorded. We have also only a small number of government and hospital recorded into this register. Next. When we put all of this evidence together of workforce assessment and geographical distribution, the service availability, and in the DHS2 workload signal, we arrive at one conclusion. We need to scale the system, not only to reporting, but first we need to invest into workforce expansion, retention, and supervision for staff well-being. Secondly, we need to integrate mental health into the routine primary health care service and also emergency response and preparedness. Third, we need to deploy resources toward underserved regions and areas. We need also to connect DHS with the workforce facilities and geographical information so that the data actually guidance the decision. Finally, we need to accountability measure service availability, competence, and supervision referral to continue an outcome. Somalia has beginning for our workforce information foundation. Our next step is to turn the foundation into the national coordinated, equipped, and competent for a resilient MHPSS system. That's all what we have in Somalia so far. Thank you all.
Thank you, Dr. Zainab. Actually, congratulations for this great effort that you are doing in Somalia, which is example of the countries that resilient country, actually clear vision, national vision, committed and motivated team, and a clear roadmap, great effort in integrating actually the mental health in primary health care, despite the challenge that you raised regarding equity. But also one of the very amazing things that the effort of integrating mental health indicator within the DHIS2 and this monitoring and analysis. So congratulations for this. And actually, I'm calling all partners or colleagues here existing in the webinar and beyond, just to convey the message that maybe collectively we need to support this national effort that currently Dr. Zainab is leading in Somalia. So congratulations. Moving for the last presentation, and Dr. Amna, I hope that you could be quick in presenting this, so we will be able to respond for some of the questions. And also, please, Dr. Zainab, Professor, if you can feel you can respond in writing in the Q&A, so this also will help us to manage the time. So the third presentation will be on building resilient mental health system, taking the FETP Mental Health Leadership Initiative as an example, which is a joint initiative currently. The EMPHNET is starting the first two cohorts in the regional cohort in EMRO, EMR, to be correct, region, where we are working in partnership with Africa CDC, but also we have a hosting countries, Egypt and Morocco, supporting this initiative, but with the ambition that we will be scaling up this in other countries. Dr. Amna is a senior technical specialist and EMPHNET. She is a public health professional, epidemiologist with extensive experience over 10 years working in supporting public health program, health workforce. She worked for immunization, surveillance, and epidemiology, and also particularly for FETP. So Dr. Amna, floor is yours.
Thank you, Dr. Neda, and thank you for having me today, particularly as we mark the World Humanitarian Day and we recognize the humanitarian workers and communities affected by emergencies. Dr. Neda, could you confirm that my slides are presented?
Yes.
Thank you. So we have heard from Professor Ragnhild, Dr. Zainab, a clear picture regarding the mental health, the needs, the burden first, the needs and the gaps, and there have been some focus also on the human resource and the workforce needs. I'll be discussing how the FETP Mental Health Leadership Initiative, as mentioned by Dr. Neda, can contribute to building resilient mental health and psychosocial support systems during the emergencies. And this would be an introduction for the initiative for the FETP mental health jointly implemented by EMPHNET and Africa CDC. So it's clear that mental health needs are already substantial globally across the East Mediterranean region, and the humanitarian emergencies add another layer. We have seen with Dr. Zainab and Dr. Ragnhild how devastating the consequences on the people living with mental health conditions, and also those facing displacement, loss, violence, and also suffering from the disruption of services as a result of emergencies. So the response to that, there are several priorities or areas for strengthening the mental health and psychosocial support in emergencies. We have seen several mentioned by Dr. Ragnhild, like the strong emphasis on multi-sectoral response and the communities, community engagement, and those with lived experience. I'm showing the WHO EMR Regional Action Plan for the strengthening the mental health and psychosocial support in emergencies. And the 5 key priority areas identified were the leadership and governance, provision of mental health, mainly provision of the service, and the workforce development, prevention of the mental health, neurological and substance use conditions, and also monitoring, evaluation, and research, in addition, of course, to what we have also talked about earlier, is the community engagement and those with lived experience. These priorities with the emphasis to be addressed across all emergency cycles, talking about doing risk reduction, preparedness, response, or recovery. Moving from this general regional priorities to country-specific actions would require definitely a lot, but I would like to zoom in two important elements, and these two have been also extensively focused on during the previous presentation. I have seen some examples from Somalia, specifically for the needs regarding the capable workforce to generate, provide, use evidence, implement, and coordinate actions and monitor results. And also, the second element is the local relevant evidence. Now, the need for local evidence to inform country-specific needs in different areas, identifying what are these needs, who is affected, where, and how, and who are needing this service, the capacities, both in terms of the system capacities and the workforce, and the gaps in terms of inequalities, who we are missing, and the performance, the interventions that are implemented. Are they accessible, equitable, effective? And any actions in terms of what to prioritize, more specifically within the countries, within each domain, what to adapt, what to expand from what is already existing, and the learning part, what worked well, and the lessons learned and what needs to be strengthened throughout the emergency cycle. Now, the gap is very big. In terms of the local evidence, based on the what is reported in the Mental Health Atlas in 2024, 36% of the countries conduct a national mental health survey in the previous 10 years. So this is a limited population level evidence. 44% routinely collect, report, and agree on an agreed set of mental health indicators. So we are looking at a weak routine surveillance and reporting. And 44% of the countries with an already existing mental health and psychosocial support system actually report on with a documented progress or impact. So we're looking at a limited monitoring and evaluation system within these countries. This leads us to the second important element, which is the capable workforce for effective mental health and psychosocial support. Recognizing these gaps means that there is a need for a workforce that beyond the clinical care, beyond the essential care and support for providing psychosocial first aid, psychosocial support, assessing patients, managing patients, towards having strengthening and evaluating surveillance, identifying trends, service gaps, generate country-specific evidence, leading mental health and psychosocial support planning, implementation, monitoring, and evaluation, and also translating evidence into policy planning and also directing resource allocation. These capacities would require the mental health and psychosocial support workforce to be trained on applied epidemiology, leadership, and developing the capacities to translate data to information to actions that shapes policies and plans for mental health and psychosocial support. So that leads us to the center for the topic for this session, which is the field epidemiology training programs. Now, the field epidemiology training programs, I will just talk briefly about them. They are on-job training program, competency-based. They are mentored fieldwork, which is the center to this program. And they focus on building surveillance, investigation, field investigation, outbreaks, and events investigation, data use for action, communication, emergency response capacities. These are well-established programs for decades. There are more than 90 programs or almost 100 programs, FETPs globally in the 200 countries worldwide. And they have 3 tiers of frontline, which targets the frontliners, typically those who are working in PHCs, intermediate level, the mid-level management, those who are working at state level, provinces, and so on, and the advanced level mainly targets national workforce. So in the region also, the program is well established across different countries with different phases of growth of the programs. The contribution of these programs to building not just individual capacities in terms of outbreak investigation, surveillance systems, and enhancing emergency response, not just individual, but also to system level. And have the numbers. We have more than or almost 18,000 outbreaks investigated from the programs globally, and almost more than 13,000 surveillance systems either established or strengthened through FETPs globally, and also there is several contributions of the FETP residents and graduates in the region. Now, taking the well-established experience of field epidemiology training program, the competency-based, field-based training, and also developing the specific track for the FETP focusing on mental health. The initiative is the regional FETP mental health established by the EMPHNET in collaboration with Africa CDC. It aims to build the technical, operational, and leadership capacity for mental health in emergencies, assessing the critical areas that we talked about, and this what will move the workforce currently working on mental health and psychosocial support from clinical care, from focusing on this clinical aspects and providing essential care, into developing evidence, translating evidence to plans, policies, lead preparedness and response recovery, communicate findings to leaders, and advocate actually for mental health among the public health sector. So basically, the regional FETP mental health works on the same competencies for the FETP, focusing on surveillance, field investigation, and applied epidemiological method, public health communication, but it is focused and tailored to the specific mental health topics. For example, for the mental health surveillance, residents will work on summarizing, analyzing, and interpreting population level data or health facility level data on mental health, including analyzing and identifying trends and patterns of priority mental health and psychosocial conditions, describing mental health risk factors, social environmental determinants, protective factors, and so on. And also evaluating mental health surveillance system and reporting mechanisms. And this is really critical part, especially for mental health surveillance. And we have seen in the previous presentations the challenge of the information system generally, but we really don't have enough evidence on what exactly is working well and what needs to be improved. What is the situation for mental health surveillance specifically within each country? So we expect from this program the residents, beyond developing their skills in doing evaluation for mental health surveillance, they will provide also evidence on the surveillance in their respective countries, which will definitely inform future planning for improving mental health and psychosocial support in these countries, generally or during emergencies. And also the same applies for the other competencies. So the first cohort of the regional FETP mental health established early in July this year. We started with intermediate FETP. The program is hosted by Egypt FETP, and there is 24 residents from 5 countries, and there is 11 mentors. The program is around 11 months, duration of 75% field-based, just like the standard intermediate FETP structure. And for this program, we employ a blended modality where residents are taught self-paced session through a learning management system. And then they have also live interaction and workshop and also in-person session. After each didactic part, they have a specific national field assignment where they implement in their countries, where they are going to evaluate surveillance system, where they are going to design specific project address a specific gap in mental health and psychosocial support in their countries, and so on. These projects are mentored, are guided by their national mentors. And for FETP, we consider mentors as the number one assets for the program. They are really critical for success of any FETP program. For this cohort, as it's the first regional one, we have a co-mentorship approach. And this was for main reason that to have the resident will have the mentorship from both, from a mentor with a extensive experience in epidemiology and also a mental health expert. So in this approach, the co-mentorship approach, having ensuring that the mentee is receiving both knowledge and their skills are, or the mentoring on topics related to epidemiology and mental health. And for this cohort, we have completed a training for the mentors for the regional intermediate FET. Now, the third tier of the program also is planned to be established in coming months. It's the advanced tier, the same duration for the advanced FETP program, 2 years, but again, it's tailored to mental health. The program is also implemented by EMPHNET in collaboration with Africa CDC, and it's hosted by the National School of Public Health in Morocco. And there is 10 participants from Morocco, Tunisia, Mauritania, and Algeria. Again, it employs the blended modality of self-paced sessions online for the didactic part, online and in-person for the didactic part, and also fieldwork mentored by national. So the expected outcomes of this training is having a cohort of trained mental health epidemiologists. They are capable of integrating mental health into public health emergency preparedness and response systems. And also strengthening the national and regional mental health surveillance and data systems. This is really would be the number one indicator of success of this cohort. How they contribute to the mental health surveillance system, whether they providing evidence on how the system is working, they're conducting robust evaluations for these systems and so on. And also a key aspect of this cohort being regional is the cross-country collaboration. And we have already started seeing that since the first in-person workshop for the intermediate FETP, where we have countries who have shared challenges, like we have Somalia, Sudan, and Libya. And this really strengthens South-South learning exchange, specifically for mental health. And definitely having country-specific evidence generated through the feedbacks of the residents, and also overall enhancing integration of mental health and emergency preparedness response. Following implementing this cohort, it would be also a critical step to evaluate the cohorts, assessing the implementation, what works well, what needs to be improved, and documenting these lessons learned and any success stories, defining the program, any additional competencies, any further contextualization needs needed across the cohorts, and also expansion. Now, we have seen that the program has 3 cohorts, 3 tiers, and we have started by the intermediate and the advanced, addressing the mid-level and the national needs. And also there is a plan to expand to the frontline tiers addressing the frontliners at the subnational level, mainly health facilities and district levels. By now, I will conclude my presentation and thank you for your attention. I will leave you with a video which have some reflections on the recently implemented or started regional intermediate FETP mental health. Over to you, Ammar.
Mental health, we have a lot of mental challenges in Somalia. A decade of conflict has created severe
Ammar,
trauma.
we can see the video.
PTSD.
For sure.
I will share it again, Doctor.
We still can't see the video. Maybe Dr. Nada, we can share the video over the chat box for the participants, so we can have time.
Ammar, maybe you can share the link if it's challenging, or is it coming? No, I don't know what's the problem. Okay, so maybe we can you share the link through the chat, so everyone can have like an overview on the presentation. And thank you, Professor, for responding for the questions. So this is make our life easier. So I will pick 3 points just for the presenter to comment on, given the short time that we left. But also in what we share with colleague after the webinar who registered for this web series, we will try to provide a written response also for the question and point highlighted along with a summary of the presentation. So one of the, I think, recurrently highlighted topic, Professor, is regarding health workers. The implication, I mean, how we consider health worker while we are discussing the mental health during emergency. So any reflection on this particularly? Thank you.
And I think there are two parts. The first is duty of care, the role of the employer, of the organizations, the institutions, to take their staff's well-being seriously, to provide training, salary, safety equipment, to make sure their staff is safe, that they have breaks, that they get supervision. That's the duty of care. And then I think there are many things we can also do for our colleagues and for ourselves, in terms of stress management, looking after our health, learning techniques, to take breaks, etc. And I think the collegial support, how to support each other, learning to take our own health seriously is very important. I could go on for a long time, but I know you have we have running out of time.
Okay, thank you. But also, if there is particular recommended guidance or anything that you would like to share, current in the chat, or we can disseminate by email later. Dr. Amna, the FETP is a strategic step in order to strengthen the scope of public health and making this strategic shift from the focus on healthcare towards addressing mental health from public health perspective, and this will help definitely at the policy level and building enabling environment. So all presentation acknowledge the gap in data, in surveillance, and its initiative here and there in our region, while it's a burning issue. So while we are strategically working in bridging this gap in human resource and try to shape the system, how can we overcome this gap now in order to draw the national attention to the mental health issue, and also to maybe increase the domestic resources allocation and donor appetite to support mental health? It's open for everyone, but starting from Dr. Amna, just to reflect on that. If you have a few ideas on reflecting on that. It's a strategic quick wins where we can get.
Thank you, Teranada. To me, there are no shortcuts. There is some evidence that can support advocacy. However, initiatives like FETP programs that shows a dual success, if I may say, or that attracts investment, not just on, we are not expecting outcomes, training people, and then they take the knowledge and go. There is the impact on the system itself. So looking at this to promote the workforce capacity building through FETPs via the win-win situation. We are building the system, and also we are training people. Of course, there is a lot of challenges comes with that. There is the turnover, and there will be the question, okay, how many we need to train? We need to train people. There is especially in the context of emergencies and so on, are we going to retain those people and so on? So we have seen with FETPs how there is an immediate outputs of these residents during the training on the system and through their field works, and also over short term after their graduation. So I hope this answers will provide some answers to your concern.
Yeah, I think yes. I think also FETP, their contribution, and the current FETP is now taking the initiative on research and answering burning question. At least it could help in shaping the advocacy effort at the national level, while we strategically work on the information system and work on strengthening surveillance and information system. So Dr. Zainab, also there is some of the questions that draw my attention. Yes, the mental health, it's some sort of multidisciplinary kind of work. However, people, this category from health workforce, with the reward they receive from the system, from the recognition, the career path, and everything existing in our national system, it seems not encouraging to have like people joining this workforce and joining the public sector. So how you say this from your personal experience, from the country experience, and from exposure, actually, given your background, also academic background and experience working in the field?
I think like in Somalia, the system, we have a lot of shortage of gather regarding mental health, and also this most of them are working in private sector. We have this shortage of image professional. It's not only educational sector problem. It's also a health workforce planning and financial system shortage. So to empower the workforce is also a big step for us. Therefore, it's required always to coordinate action across ministries, universities, professional association, and employment development partner and community. In Somalia, we try as much we can to fill this gap by connecting with the universities and creating cadres for mental health. And I hope, and hopefully we success in some university that establish the program for degree of psychology, even though we still, for psychiatric professional, they go outside of the country, but it always worked for us that we could have some universities that now provide that degree. So it is short, it's long-term to go for all university to adopt this professional to have a mental health professional. But I think we started, and last 2 years we did a lot of work regarding to universities, and we're hoping that the next years, coming years, more universities join this effort and to create a positive income. And also it's always helpful that the medical association and mental health association are doing this also advocacy. So now we have a lot of junior doctors that now going outside for to become a psychiatric or clinical psychologist and coming back to the country and opening new clinics that always cover the shortage of the system we have right now in Somalia.
Okay, thank you, Dr. Zainab. I think you highlighted like this public-private partnership to bridge the gap. Also, the professor previously and also some of colleagues here commenting in the chat highlighted the task shifting as a short-term strategy that could bridge the gap. But definitely, again, the key areas that you highlighted, that there is a need of more advocacy for this particular health workforce and specialty in order to encourage and to have a strategic policy at the national level to encourage increasing the health, this workforce, but also some sort of retention policy that could help sustaining and maintaining this critical cadre to be functioning, particularly in the public sector. There, maybe in 2-3 minutes, Professor, if you can highlight also practical steps on integrating mental health and psychosocial support within the system, and particularly in primary health care system.
Thank you. Well, I think one very important thing we need to do is to look at our pre-service training. The doctors and nurses and psychologists need to learn while they're still in training about task shifting, about how to support and supervise others, so that we can create sustainable integration. And I think a good referring system also becomes very important. And to think also is community-based and task shifting, so that we don't end up using resources in the wrong way. But that will require supervision and a lot of insight from the specialists as well.
Okay, so I think, yeah, I think the country is now, it's a high time to start mapping what's available through the different level of care existing in the country. Try to define a package where task shifting and task sharing could be a solution to provide the package of care required to think beyond the setting of the public health, including school and other part that you highlighted during your presentation. I'm just trying to recall from here and
well done.
And there, yes. And in order to make sure that definitely one of the key elements that highlighted through the FETP presentation were the gap in surveillance information system. And we have this good example from Somalia, where we try, maybe it's good also to have this function integrated within the system, where evidence comes, proper advocacy at the national level. Definitely, if there will be a fruitful outcome on mobilizing more commitment at the national level and more commitment from the donor and partner to prioritize the mental health as an agenda. And just try to open for you three, since we are talking about humanitarian, and we can observe like a growing substance use disorder happening as an outcome of this humanitarian crisis, which is again stigmatizing overlooked mental health related public health issue. So from the different initiatives that you presented today through your presentation, maybe one key message or two key direction that through this program we can help to serve this agenda, or again to address this issue. So starting from home. Dr. Amna, would you like to come in? So how FETP could help in addressing the issues related to this?
I think Ragnhild, for me, a key message from this webinar, and specifically when it comes to the human resource part, the workforce part, is that they need to move beyond the clinical focus when it comes to building the capacity for workforce working in the mental health and psychosocial support, bringing in the capacities in terms of planning, leading interventions, monitoring, evaluating interventions, developing the skills to work on surveillance specifically for mental health. And even for me, when I was working on this initially, when working in planning and so on, to me, I come from a background as epidemiologist. But looking at mental health issues, I would be looking from epidemiology angle. For mental health specialists, if they have these capacities, being the epidemiology angle, definitely they will diagnose the issues better, and they will come up with more relevant solutions to mental health. I hope this,
Thank you. Dr. Zainab, please.
I think it's important in Somalia. The mental health is not only optional in humanitarian to add on, but also mental health is core health system, resilient and function. And to touch all these is very important that to operational level to for emergency response to cover the mental health part. In Somalia, where rational is always in demand for mental health service, but to build a resilient health system is required to move beyond short-term project and head country, and we have to establish a more national, coordinated and supervised, equitable workforce. That is much important. We must also translate it from the country workshop of attending or validation for clinical competencies is important for workforce. So regarding the point for substance use, now we are working on it with the EMRO region. Since the substance use is in the flag sheet, so we are working morely to increase the awareness regarding the substance use and to more engage the youth that affected by this. Thank you.
Thank you, Dr. Zainab. Professor.
Thank you.
Please.
I have two messages, I think. First one is that mental health is a positive thing. We must also do all we can to promote good mental health, to promote social support, to make sure we can contribute to society and build our resilience, not only focus on treating conditions. That's the first one. The second is that I agree with my fellow speakers, we should all contribute to building resilient health systems that prepare for emergencies and respond to emergencies. And when we do have to have emergency humanitarian aid, it should not ruin or harm the existing system, but continue to strengthen the system. There's enough misery. We don't need to compete and make parallel systems. We should try to work together.
Okay, thank you. I think this is one of the very interesting topic and a very amazing speaker that we have. Thank you for staying with us beyond the webinar time. but also for the suggestion and the comment that we receive in the chat. And yes, and I think one of the comment that the webinar, all in the webinar are female. So I think that now this is the power of women coming in and influencing the public health system. There is a suggestion on establishing a platform for advocacy for mental health. And I think this is, again, a collective effort. We at EMPHNET is very encouraged to be part of that and to support for EMR, but also across the continent in Africa, building on our strategic partnership currently we are doing with Africa CDC throughout the different pillars of the mental health initiative and leadership that the Africa CDC is promoting, and also definitely at the national level. It's very important, critical. I think it's a very successful selection of mental health, linking it with the Humanitarian Day. Humanitarian Day, we used to talk about rapid response team, outbreak, infectious diseases. So also this is a strategic shift when it comes for celebrating Humanitarian Day, talking about mental health. So I think our webinar today is just like a drop in an ocean, because there is a lot of agenda waiting for us to support mental health in the continent, in the region, but it's in a start. So we are welcoming all the voices or the advocate working with us, with the ministries, with EMPHNET partnership with the ministries of health and across different sectors, social sector, association, CSOs, and definitely our strategy partner Africa CDC in working on that. And thank you for staying with us, and wish you a very happy good evening, and assalamu alaikum.
Thank you.
Thank you very much.